Pressure injury prevention in acute care settings. Can the preventative application of foam dressings to patients with a Braden scale less than 19 on admission to the hospital decrease the development of pressure ulcers? In other words, we want to use these foam dressings to keep the skin looking like this, so that way this does not happen to patient's skin. Pressure injuries are costly to treat. They nearly cost $9.1 to $11.6 billion per year on treatment. Cost per patient can range from $20,000 to $151,000 per year. Pressure ulcers can also cause more than 17,000 lawsuits annually, the second most common claim after wrongful death. Pressure injuries can also increase the length of stay. Pressure injuries worsen patient outcomes by increasing the length of stay from 5 days for patients without pressure ulcers to 13 to 14 days for patients with pressure ulcers. Mortality rate can increase from 2.6 for patients without pressure ulcers to 4.1 to 11% for patients with pressure ulcers. And lastly, high incidence of hospital-acquired pressure ulcers in any organizations may imply poor quality of care. Who is affected? Patients, providers, nurses, dietitians, family members, insurance companies, pharmaceutical companies, home care agencies, case management, wound care teams, administration, physical therapy, surgery, employers, and quality control.
So what do we currently do to monitor our patient's skin? We do a full, thorough assessment as per protocol with increased attention to bony prominences, monitoring for any evidence of the start of breakdown. We keep the patient turning at least every 2 hours. We do frequent incontinence checks and utilize the proper bedding materials like Chuck's pads, paper pads to keep the moisture away from the skin. And we involve dietitians to monitor nutrition status, making sure that the patient has enough protein to repair any kind of breakdown and maintain integrity of the skin. We use a Braden scale to assess for risk of breakdown. By assessing the patient, we can give a number from 6 to 23 that will tell us if they are at mild, moderate, high, or severe risk for any kind of a breakdown. Our change is to plan and prevent breakdown by intervening sooner, applying a foam dressing when the patient hits 19 or results in a number less than that. This is an example of a graph used to find the number for the Braden scale. It's based off of sensory perception, moisture, activity, mobility, nutrition, and friction and shear. Changing our nursing practice, we want nurses to be able to apply a foam dressing based on their skin assessment before evidence of breakdown. We want the nurses to be educated and know that they can look at that patient as a whole, critically think ahead, and place that dressing without order from a provider.
Committees that are available for the most current information regarding pressure ulcer and pressure ulcer prevention are the National Pressure Ulcer Advisory Panel, who served as the authoritative voice for the improved patient outcome in pressure injury prevention and the treatment through public policies, education, and research. The National Database of Nursing Quality Indicators, which is where prevalence data is recorded quarterly. The Wound, Ostomy, and Continence Nursing, which closely mirrors the National Pressure Ulcer Advisory Committee practices and relays information to nurses on a monthly basis. Synthesis number 1 was based on an article titled Understanding Nurses' Views on a Pressure Ulcer Prevention Care Bundle, a Step Towards Successful Implementation. This was a qualitative study. The purpose of this article was to explore nurses' views of the barriers and facilitators to implementing a patient-centered pressure ulcer prevention care bundle. As the authors state, there must be some real perceived benefit for individuals to adopt new interventions. The findings were the success of implementing the preventative care bundle depended on the willingness of the patients to participate, as well as the nurse's willingness to incorporate this into their routine. The relevance of this study was that understanding barriers and facilitators to uptake is a prerequisite for successful adoption of a new intervention. Feasibility is that this is low cost to the organization to implement, and resources needed would mostly be related to the cost of educating the staff to their proper use. Benefit is that the initiation of a pressure ulcer prevention bundle may facilitate both active patient participation and a more consistent implementation of these bundles among the nurses. Despite recognizing that the importance of pressure ulcer prevention strategies exist, they are still not consistently implemented. The barrier to this study was that it only involved nurses from one hospital who were interviewed, and they had different degrees of familiarity with this particular bundle, which limited its generalizability. Synthesis number 2 is based on an article titled 5-Layered Soft Silicone Foam Dressings to Prevent Ulcers in the Intensive Care Units. This was a quantitative random controlled study. The purpose of the study was to compare the incident rates of sacral hospital-acquired pressure ulcers on critical care patients receiving standard skincare bundles and those who additionally had a preventative foam dressing applied to their sacrum on admission. The findings were a statistically and clinically significant benefit was noted for the application of this foam sacral dressing in the prevention of hospital-acquired pressure ulcers. The relevance is that the reduction in these hospital-acquired pressure ulcers is noted when using foam dressings preventatively along with the standard skincare bundles, and that gives support to the evidence-based practice we plan to implement. The feasibility for this is that the cost would include purchasing foam dressings and in-servicing staff, which is a relatively low incurred cost. The benefit would be reduction in these hospital-acquired pressure ulcers, realizing a great cost saving by patients as well as the institutions, and that there would be better patient outcomes, as in their length of stay would be decreased and their incidence of infection and additional costs would be lessened. The barriers for this study was that it was on a single site versus multi-site study, and they only included the critical care patients in critical care units, thus limiting the generalizability to the other populations of hospitalized patients.
Synthesis 3 was a systematic review regarding the effectiveness of pressure ulcer prevention strategies for adult patients in intensive care units. The purpose was to synthesize the best available evidence regarding the efficacy of single strategies to prevent pressure ulcer development in ICUs. What they found was that there was a statistically significant effect of a silicone foam dressing at reducing incidence of hospital-acquired pressure ulcers in ICU patients, especially when focusing on sacral and heel ulcerations. This is relevant to our change because it shows that the use of a foam dressing as a preventative measure is effective. Feasibility, this is definitely applicable to our organization. By preventing that breakdown of skin by using the foam dressing, we can decrease cost of patients, as was previously stated. And it would only require a change in policy, some staff education, and making sure that we have enough dressings on units. The benefits would be high. It would, as previously stated, decrease length of stay, decrease costs, and complications that can come with development of pressure ulcers. Barriers to this review, as the author stated, were that among the studies there were different staging systems used for pressure ulcers, small sample sizes, and a lack of randomization. Also, this was focused on ICU patients, limiting the generalizability across populations.
Synthesis 4. This explored the patient's perception of pressure ulcer prevention care bundles in hospitals. It was a qualitative descriptive study to guide evidence-based practice. The purpose was to identify patients' perceptions and experience of pressure ulcer prevention care bundles in a hospital. The findings: positive perceptions were based on personal contact with research assistants in pressure ulcer prevention care bundle delivery. The understanding of pressure ulcer prevention enhances participation, and individual personal factors impact the engagement of pressure ulcer prevention. Relevance: understand the reasons that motivate patients to participate in self-care. Feasibility: Implementation would be easily achieved. Costs associated with this change would be minimal by providing staff for patient education. The benefit would be the education of the patient on pressure ulcer prevention that reduces the cost of treatment, time of stay, patient pain, and risk for infection. Risks or barriers of the study would be noncompliance of the patient, lack of understanding of education, and personal barriers such as age, cognition, and mobility. Synthesis 5. This article explored foam dressings for treating pressure ulcers in patients of any age in any care setting. It was an abridged Cochrane systematic review. The purpose was to assess foam dressings compared to other dressings in healing pressure injuries. The findings were unclear if the foam dressings affected healing time to complete healing or the reduction of pressure injury size because the certainty of the evidence was very low. The relevance determined which type of foam dressings are more clinically effective, more acceptable to users, or more cost-effective when compared in treating pressure injuries. Feasibility. Change could be implemented easily since foam dressings are already being used. Change would include brand of foam dressings being used and the purchase cost. The benefit would be the cost of the utilization of foam dressings that could be reduced by purchasing the less costly brand. The facility is more likely to implement change with reduced costs. Risks or barriers of the study. Researchers' potential biases during evaluation and the variability of reporting between the studies could have affected the results.
The change that we plan to make is enabling nurses to apply foam dressings sooner rather than waiting for evidence of breakdown. We will teach the nurses to use the Braden scale to appropriately apply a foam dressing and to realize that they do not need a physician's order to apply this. We also want to make sure the nurses know that the foam dressings are to be used with existing skin care protocols, not in place of.
Resources would be to develop rounding teams, including nurse educators who would design the in-services, the skincare nurse to reinforce new information and policies, management to have the supplies available to utilize, quality improvement who would track statistical improvements, policy writers to update policies that reflect nurses' autonomy, and super users who would be present on each unit to support this new practice.
Implementation and evaluation. The use of foam dressings as prevention can be used in any setting ranging from ICU and OR to long-term care facilities. But for our implementation, we will be using an acute care setting, being a medical surgical unit in the hospital. The changes would be implemented with an initial in-service educating the nurses about preventative application of foam dressings, weekly reminders of skin breakdown prevention, continuing education, wound rounding, and monthly wound statistics would be taken. The stakeholders, as previously mentioned, would still be the same. And for evaluation, we will track the amount of hospital-acquired pressure ulcers in patients over a 3-month time period after nursing staff receives the in-service and other wound care training.
Integrate. Changes are communicated through holding mandatory in-services for all RNs on all shifts. These in-services will include detailed information on the evidence-based practice change of the use of foam dressings as a preventative measure to inhibit the development of pressure ulcers. A PowerPoint presentation will include a review of the Braden scale and identify common areas of potential skin breakdown. An instructional video is included that shows the correct application of foam dressings. Also, posters in employee areas will address the current practice of the skin bundle approach. The way to integrate change into policy is through facility-wide email notification to all RNs. Also, a wound care specialist team will be established to perform patient care rounding to initiate and train the new policy facility. Maintain. Plan for monitoring change and outcomes. An RN self-report survey is given that includes compliance of new protocol, self-evaluation of education of new policy, opinions that include pros and cons, and beliefs if the change is effective, and suggestions to enhance new policy. Statistical data comparison of prior and post-pressure ulcer development can be done with a quarterly annual review. Also, a cost analysis can be performed to compare cost of treating a pressure ulcer versus the new cost of preventative foam dressing application. Dissemination of the results. We would share the results using facility newsletters, placing posters on units, and email notifications of results of the pilot.